The Rhinology Room. Conversations beyond guidelines.
Hello.
Morning.
Good morning. Why your cup is larger?
Because
What is this?
this is mini shot for you.
Okay, thank you anyway. Hello.
Hello, good
Good
morning.
morning. We are at
Penjakiti.
it's a
Yeah.
park. It's
Yes.
a park.
It's a
large
park.
park.
Large park, yes.
Yeah. You love doing exercise,
Yes, I
working
run
out.
here a lot.
Mhm.
Yeah.
Oh, okay, my first time here.
Oh, wow, you don't run?
No.
Okay.
Well,
Cheers.
cheers.
Morning.
Now, let's play again.
Oh, morning game.
Yes.
Okay, I'm ready.
We will discuss about chronic rhinosinusitis,
Okay.
treatment and surgery.
Okay, I think you have one right now.
Yeah,
Okay.
that's not the point.
Okay.
I give you two kinds
Okay.
of chronic rhinosinusitis treatment.
Okay.
Just pick one
Okay.
without any thinking.
Okay.
Okay, pick one immediately.
Okay.
Are you ready?
Without thinking.
No.
Okay. Use my brainstem.
Yes.
Okay. Sure. Ready.
Antihistamines or antibiotics.
Antibiotics.
Antibiotics or steroid spray.
Star spray.
Steroid spray or montelukast.
Star spray.
Steroid spray or steroid irrigation.
Star irrigation.
Steroid irrigation or baby shampoo irrigation. Tick-tock, 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 tick-tock.
Star irrigation.
Steroid irrigation or dupilumab.
Star irrigation.
Steroid irrigation or FESS.
Face.
FESS or full house.
Full house.
Full house or balloon.
Full house.
Full house or straight flush.
Huh?
You don't know straight flush?
Okay, I pick one because I don't know what it is.
Come on. You don't play cards?
Oh, that's a treatment. Okay.
I would prefer straight flush.
Okay, straight. Yeah, okay. I don't know what it is.
Yeah. You're a good girl. But interestingly, you would prefer full house? Huh?
Depends on the goal of the surgery, right?
Mhm. Like what?
So every CRS we report back to the endotype,
Yep.
and each endotype have different purpose of surgery, right?
Okay.
So full house is not for every cases.
Yeah.
So we should use it selectively.
Okay. Yeah, I think one thing is we work in the tertiary hospitals. We see a complicated case,
Yeah.
which may be different from other doctors.
Yeah.
So most cases of us, right, have diffuse inflammation,
Yeah.
or they may fail to previous surgeries.
Yeah.
Yeah, so I agree. Most surgery of mine is full house.
Right.
Mhm.
So because we are in tertiary care, we
Mhm.
mostly get difficult or almost like failed surgery.
Yeah.
Failed medication already.
Right.
Right.
I think one thing is we work in the tertiary care.
Yes.
And other doctors may work in the primary or secondary care.
Mhm.
So we see different kinds of patients.
Yeah. True.
Most patients of ours are diffuse inflammations, polyps, type 2 inflammation, or very complicated cases.
Yeah.
So it depends.
Yes.
Okay, I really agree. But one thing is, there's very kind of FESS,
Yes.
right? Or ESS, or mini FESS,
Yeah.
or full house,
Yeah.
or reboot,
Yeah.
balloon,
Okay. Yes.
drill out.
Real. Yes.
Yeah.
Okay.
So if when the patient failed the surgery,
Yeah.
and the doctor informed them that they require surgery,
Yeah.
from the angle of the patient, they think that there's one kind of surgery,
Right.
So ESS, if they may think that there are two kinds. One kind is endoscopic approach.
Yeah.
The other kind is open approach
Right.
in the patient's angle.
Oh, do you think so?
Yeah. So when the patient get informed
Yeah.
about endoscopy surgery, they may shop around, but they never think that FESS from one hospital will be different from FESS from the other hospital.
Yeah, I think it may be too complicated for patient to understand, right? What
Yeah.
are we really doing? Because
Right.
yeah, I think it's from patient perspective, the anatomy itself is very complicated.
Yeah.
And the surgery that we do is, I don't think it's easy to understand from patient's perspective. So
Yeah.
do you want to clarify a little bit of what is the ESS or what is phase? What is full health phase?
I think maybe 20 or 30 years ago, we are quite familiar with the term functional
Yeah,
endoscopic sinus surgery
Yeah.
or FESS. But the functional means that they get the sinus back to its functions.
Yeah.
So they promote the ventilation, the drainage. They talk about the pre-ethmoid chamber
yeah,
that contribute a lot to osteometal complex occlusions. So the FESS we correct this anatomical obstruction.
right.
Yeah.
Okay.
But after a while, we know that FESS is not the solution to all patients.
True.
So people start to use the word ESS, endoscopic sinus surgery.
Yeah,
It's not only functional.
right.
But
So it's like
yeah.
ESS is like a big umbrella of like phase and
Yes.
other surgery.
Yes.
So ESS is like terminology for any kind of endoscopic surgery, right?
Yes,
Yeah.
true.
Okay.
But FESS is a very popular term, so most people still use the term FESS
Yeah.
or FESS course.
Right.
For FESS course, we learn a lot of things.
Yes.
Variety of sinus surgery,
Yep.
not only FESS. Yeah. And then there is a mini FESS, limited FESS
Yep.
that they may do limited ethmoidectomy. They may just open up the middle meatal antrostomy.
Right.
Uh,
Okay.
and then there's full house.
Yeah.
What is full house? You would prefer full house?
So full house is basically connecting all the sinus together, right? So it becomes the same chamber,
Yeah.
right?
Yes, but not all doctors have the same understandings.
Okay.
You say that you create a common chamber,
Yeah.
a common cavities, but I think most doctors' understanding is if they touch all sinuses,
Yeah.
they open all sinuses,
Right.
that is full house.
You mean even though it's not like fully connected or just like a mini like enlargement of the osteum that's
Yes.
like full house already.
Uh-huh.
Okay.
Yeah, they manipulate the frontal sinus or frontal recess.
Yep.
They open up some ethmoid cells. They open
Yeah.
up the maxillary sinus,
Yep.
sphenoid, or maybe not, maybe no sphenoid. They
Right.
still call it full house.
Right.
Yeah.
And what problem do you face when you see these kind of cases?
I think the problem is from the patient understanding that
Yeah.
I mentioned before. They do not know about this variety, but they search, they Google,
Right.
they ask the AI,
Yeah.
but they are not clear, right? So I think you feel the same that some patients of yours go to Google upon tip and they are quite afraid reading about the complication,
Yeah.
reading about bleeding,
Yeah.
suffering,
Yeah.
painful surgery.
True.
Mhm.
Yeah, I experience the same thing. So patients often come to me and ask about surgery. Is it like going to be a complication or is it going to be like a lot of pain? I
Yes.
experience the same thing. And they shop around
Yes.
because they feel like they want different opinions. And sometimes when the doctors give different perspective, they
Yes.
start to get confused.
Yes. This is the good
Yeah.
point. Because when the surgeon gives different perspectives
Yeah.
in the angle of the surgeons,
Yeah.
they think that this is the good surgery,
Yeah.
and they may do full house to all patients, or other doctors may do limited FESS to all patients.
Yeah.
They may think that full house is not necessary.
Right, right,
Why do we
right,
need to
right.
open up and create a common cavities?
Yeah.
Uh,
So we should really step back and actually look at the purpose of the surgery, right?
Okay, yeah.
Because each disease have different purpose of
Right,
surgery.
right.
Yeah. So should we give a little example of each kind of disease endotype that maybe need limited surgery and some disease that need full house surgery?
Yeah. For limited surgery, I think the aim is just to correct the osteometal complex occlusions. So it means that the patient should have focal disease,
Yeah.
at
Focal
that
disease,
area.
yeah.
Yeah, focal disease, not diffuse inflammation in
Right,
all
yeah.
sinuses. So
So if
just
you
correct
refer
it.
back to the EBOS 2020,
Yeah.
they're going to be like the isolated sinusitis.
Yes,
So that
yes.
one might be
Right.
a candidate for limited
Yeah.
surgery. Yeah.
But it's not necessary to be maxillary sinus. It can be sphenoid
Yeah,
sinus,
true.
isolated
Any
sphenoid
sinus.
sinus, isolated frontal. So you just correct the ventilation and drainage of that particular sinus.
Yeah.
But then if the patient have diffuse inflammation,
Yeah.
what they need is the common cavities.
Yeah.
For the long-term local management,
Yeah.
right? You need a topical nasal saline irrigation. You may add steroid into the irrigation,
Yeah,
right?
true. Yes.
Do you add baby shampoo in the irrigation?
Did you teach me that?
No.
Okay.
But your patient may ask you. Be aware.
No, I never have any patient ask me if they use baby shampoo.
But be aware, some patient may have non-functioning sinus.
True. Yes.
It means that the mucociliary of
Yeah.
that sinuses are not working any longer.
Yeah. I have one patient that I recently operated. He has fungal ball probably for my 10 years, and he just decided to do surgery. And then when I opened up the cavity, just MMA,
Yeah.
and then later on, in a few months' time, I can see that his sinus is not functioning anymore because there are a lot of like sumping of the mucus and pus, and even though it's
the
already
cavity is good.
yeah, even though the cavity is good. So I think that because of the fungus, it's very inflamed for a long time.
Yeah.
So the ciliary clearance is not working anymore. Yeah.
Very true.
Do
Okay.
you see the same piece? Yeah.
Yes, because when the cilia is not working, they
Yeah.
inhale fungus.
Yeah.
And the fungus stay there.
Yeah.
And then
Long enough.
Yeah. There's a growth.
So,
of
but at the
fungus.
time of surgery, we didn't think I wouldn't do
So in that case, MMA should not be a solution.
but I mean like at the first surgery, would you do drill the maxillary wall right away?
For type 2 inflammation,
No,
yes.
for fungal ball.
For fungus ball, I think there are two schools of thought.
Yeah.
But I think I need to assess the patient individually.
Yeah.
It's different
How?
from cases to cases. From the clinical, if there must be a reason why the mucociliary is not functioning there.
Yeah.
There may be previous trauma at that area.
Yeah.
They may have previous surgery at that area.
Yeah.
Or what happens if I suspect that there must be an explanation.
Yeah.
I will do the drill out right
Okay.
away.
At the first
So in some
surgery.
cases, yes.
Can actually CT scan can predict the non-functioning sinus? If like the bone is very thick, like osteoneogenesis, like very thick, and then you might suspect that the cilia might already like not function anymore.
Especially bone scar.
Yeah.
Especially soft tissue scar.
Yeah.
When you do nasal endoscopy and you observe the scar,
Right.
you should not expect the mucociliary function at that scar, right? There are no
True.
cilia.
But I mean, scars come from previous surgery, right?
Yes, yes.
Right. So, but if the patient didn't have previous surgery before, how do we assess that?
That is the other school of thought, right? Why waiting? Why don't we do drill out at the first place?
I see.
Because there's no complications.
Yeah.
The patient is satisfied with the first surgery, so you just drill out.
Okay. Yeah. Okay.
But I will not say which one is right or wrong, but
okay.
there's school of
Yeah.
thought and debating.
I think for me, if it's in the sphenoid and the bone is very thick, then I would prefer sphenoid drill out.
Yeah.
But if it's in the maxillary sinus and the bone is not that thick, I wouldn't start with the EMM. I might start with the MMA first. But I can see why that some surgeons prefer to drill in the first surgery.
Yeah, and to me it makes sense.
Yeah.
But I like you. I like what you say and what you do.
Okay. How about
but
other examples?
The example of the
Other
drill out.
endotype?
Okay. We mentioned about type 2 inflammation.
Yes.
And they produce a thick mucin, eosinophilic mucin.
Yeah.
They have polyp.
Yeah.
And we discussed before that polyp is a clinical presentation.
Yeah.
It's not a disease.
Yes.
So we should think about how we should manage the cavity in the long term.
Yeah.
So this is the other aim that we create the cavity for further topical management.
Right.
And not only the irrigation, but also the patient can clear the thick mucin out by themselves.
Yeah. Even in the operation room, it's really hard to get the mucin out, right?
Yes,
Even we have the large bore suction, it still like take forever to take it out. So I can imagine that because the CRS is not heal after surgery. It's a long-term inflammation that is going on. So I can imagine it's so hard to irrigate at home by themselves, especially in the area that is hard to reach already, like frontal. Yeah, so it must be very hard. So sometimes if they have a very inflamed, like type 2 CRS, sometimes full health phase is not even enough, right?
No. So you mentioned about drill out for non-functioning sinus at the first place. What about drill out for type 2 inflammation at the first surgery?
So, so if I encounter a patient with very inflamed type 2 CRS, so we have a little prediction that we want to do out. So first of all, very severely a lot of polyps in the nose. They may have asthma or very high serum eosinophils.
Yeah.
And the bone is very thick, right? So in that case, I might prefer to drill the bones. For example, if it's like the maxillary sinus, I might do EMM. For the sphenoid, maybe drill out. For frontal, it's either Cairns window or strap 3. Yeah.
So there's a role, right, for primary surgery that you may drill out. The other thing is when you mentioned about type 2 inflammation. Within this umbrella, there are a lot of things in this umbrella, in this basket. Like, for example, the patient may have ECRS.
Yes.
The patient may have allergic fungal rhinosinusitis. Some patient may have NERD.
Yeah, NERD.
And some may have CCAD. They are all type 2 inflammation.
Yeah.
But not all of them require the drill out as a primary surgery, right?
Yeah.
But for NERD, for example,
that's neat.
We cannot correct the cause, right?
Yeah.
So usually the patients are asthmatic.
Yeah.
And they're severely inflamed from ERD.
Yeah.
I may do primary low drops.
Yeah, right. But for CCAD, that's a different one, right? Because it's CCAD, central compartment atopic disease, is actually the severe result of allergic rhinitis, right? So it's caused the OMU obstruction. So I don't think they need a drill out.
No, I did not drill out CCAD patients.
True.
So interesting.
Yeah,
right?
Interesting.
Yeah. So FESS is not always FESS.
Yeah.
And FESS are not all the same.
Yes, it's not all the same. So I think we really have to go back to basic, right? So we have to understand the disease first, and then the purpose of the surgery and the goal of surgery. So for example, number 1 is to correct the ventilation and drainage of the sinus. Second of all is to promote the mucociliary clearance. Third of all,
remove all the thick mucus.
Yeah, the thick mucus. And third, to actually help the sinus is not functioning anymore, right? And the fourth one is to get the steroid irrigation into the sinuses that need steroid.
Or even saline irrigation.
Yes, or even saline irrigation.
They may require aggressive topical management in the long term.
True, that is very true.
Yeah, very good points.
Yeah, good point. So cheers again.
Cheers.
Very early.
Okay.
See you next episode.
Goodbye.
Bye bye.